Okay, fantastic. So we've had three amazing talks on three different pathogens of relevance, and we've got a small but fantastic cohort in the room of in-room attendees, and I can see that we've got a whole bunch of participants online. So I didn't provoke you to think about what your questions were going to be for our speakers before, but I hope you've been thinking about that already. I'd like to invite some questions from the room, and I can see handsome gentleman up the back with raising his hand. I'm not sure who he's going to ask though.
Uh, so Jason Roberts here. Thanks very much to all speakers. I really enjoyed all those presentations. Topic that I know very little about, but with the first presentation, I zeroed right in on a potential pharmacokinetic issue, which got me a little bit excited. So it relates to the cabotegravir combination product, and one of the risks of failure um, that was identified was obesity, and I assume that that's a subcutaneous. It's a
Deep intramuscular injection.
Okay. So I was going to ask whether or not there had been any pharmacokinetic evaluations of the behavior of that drug in obese versus non-obese patients to see whether or not it's exposure related or whether or not it's something related to the patient's physiology um, and obesity itself, which actually drives um, the reduced effect. And so interested in the viewpoint on that.
Ethan, would you like to take that?
Yes, thank you. Great question. It is something that has been looked into, but I haven't looked um, uh, intently at the data before this presentation. I do believe it is related to, so as Andrew said, it's a deep intramuscular injection. And so I think at least part of the concern is about getting the injection into the muscle as opposed to predominantly being subcutaneous. And so for that reason, both the manufacturer as well as international guidelines recommend that in people who particularly have a BMI over 30 and or have more, let's just say, ample subcutaneous fat around where the injection is going to be, then a longer needle is definitely recommended. But it's a good question, and it definitely is one that there's a lot of work in a PK/PD space in terms of these long-acting medications because of, I think, the potential issues for um, uh, the affected or altered pharmacokinetic, pharmacodynamic properties associated with very long-acting injections.
Thanks, Ethan.
Right. So, I mean, I guess I guess, clinical correlate is that we have, it has been identified that people of this higher BMI are at statistically increased rate of treatment failure, and so clearly there's something going on. And there has been some work done into it. Unfortunately, there's not TDM available for these medications for us for clinicians to deal with, and so we've been relying on really researchers doing that PK/PD work, but essentially in our hands, it's very, treatment failure is incredibly rare in this circumstance. I guess just that'd be the overall caveat. So we've got this lovely surrogate of adequate drug exposure. Um, Great. Any other questions in the room? I'd like everyone to feel very welcome to do so. I've got a couple of little questions that I've thought of along the way. And I don't know if there are questions online. There's one for Dr. Sweeney from Yvette Davidson. Any thoughts on the Hologic MGen macrolide resistance assay? It's available on their open access system as a laboratory developed test. I'm potentially looking into this assay, and your presentation has given me great ideas for questions I will ask regarding markers used, etc.
So, excellent question. I think from memory, the hologic assay covers the 5 common 2058, 2059 macrolide resistance mutations, but I don't think from memory it covers the wild type. So it will tell you whether or not there are macrolide resistance mutations present, but again, it misses out on that wild type where you're the absence of detecting a resistance mutation then infers susceptibility. This is not necessarily just a hologic thing. I think pretty much every test on the market only covers either wild type or resistance. It doesn't cover both. But I know that there are assay developers out there actively looking at this and trying to implement both a wild type and the resistance mutations. I was on a call earlier today, actually, with people in the US, and because they don't have any FDA approved assays over there, they're actually using their own in house assays, and they're now including the wild type as well as the resistance mutations for macrolides and also for quinolones as well. So it's definitely something to be aware of because I don't think, especially as clinicians, I know lots of people are quite time poor. Unless you really dig, you often miss out on some of these sort of nuances for the assays. So yeah, it's definitely a fair point. I unfortunately can't comment on LOD or sensitivity or anything like that for that particular assay off the top of my head, but I'd be happy to chat with you afterwards as well if you'd like.
Great. Thanks so much. So look, we've got another question online, and Ethan, it's coming your way. The uptake of injectable antiretrovirals has presented a significant unfunded and burden on hospital clinic-based HIV services. So they're models that you're aware of for translating administration into the community, either whether that be pharmacy, community pharmacies, or primary care. Ethan, I'll let you take that.
Yes, it's a great question. So yeah, and you're right. So somebody who's on Cabenuva regularly, you're expecting to see them 6 times a year, as opposed to most clinics will see their clients on oral therapy once or twice um, in a 12-month period, and so it's a fairly increased amount of patient time. There are some instances that I'm aware of. So I think we've got one person, we've got about 25 to 30 people on Cabenuva at this clinic that I'm working at currently. Similar numbers at RPA Sexual Health in Sydney, where I was at last year. There are we've got one client at Gold Coast who gets his Cabenuva predominantly through his GP, and the GP is happy to do that, and we see him for routine monitoring. At the ASHM conference last year, there's a high caseload GP practice in Perth that has moved to doing Cabenuva injections at their clinic. However, there is a bit of that was only able to be done with external funding to allow that to from the drug company itself in order to allow that to happen. Additionally, there is, I think, in there's moves from a pharmacy in Queensland to be able to offer Cabenuva administration, though that's still very much in a planning as opposed to a pilot or it being readily available. The newer agents that are in development, you'll note, have a longer gap in between administration. So you're looking at between 4 and 6 months potentially, which I think will be markedly better, both from, I think you'll see a much greater desire and uptake from patients, as well as potentially a much reduced burden on clinic time. One of the issues is that I think one of the agents that's in development, the BNABs, are generally given via intravenous administration, which I think every pharmaceutical rep who's suggested IV administration has gotten feedback that that's not really something that would be able to be done in most outpatient sexual health services, or even wouldn't be particularly appropriate in a hospital setting where a lot of patients, particularly, may not feel comfortable going to the ambulatory care day clinic type presentation setting for their IV administration. So yes, in short, there are programs that are in development, um, but also I think with the development of newer drugs, they will have more amenable time differences between doses that will allow for reduced burden on clinics.
Yeah, look, that's a great question and really well answered. Thanks very much, Ethan. Look, Sam, I'd like to ask you, you've had a chance to refresh your throat now. Um, you raised the specter of just progressive drug resistance in gono, which is it's always had, and then there's a handful of new agents that have been looked at, where it's gepotidacin or soliflodacin. Do you see that there's a pathway to more proactive approaches to this? Because clearly you're sequencing lots of isolates already, and why are we not looking at, or is there a challenge for understanding what the markers of resistance are for new agents? What do you see as the challenges and potentially the opportunities there?
I think that part of the issue is that it's a really, really mutable bug. And we have almost always looked at gonorrhea through a clinical lens, which has rendered a lot of the research relatively reactive, in my opinion. I do think that there is some basic science work to be done on gono in order to identify new treatments, because in part, I mean, with uh, horizontal gene transfer, antimicrobial resistance, um, in discussion and kind of under investigation in other bugs in recent years. We've kind of been looking to, okay, well, like, how does horizontal gene transfer work with CRISPR systems, work with other things? So I think there is a couple of things here. One, we need to know a little bit more about the bug from basic science kind of perspective. Two, I do see from my public health role that there is like a little bit of a lack in translation efforts from even just in taking the surveillance data that we have and getting that out to the right places. We live in a world where we have instant messaging, so I don't think it should necessarily. Maybe that's my bias, my age group. Maybe there is like a space where we should be working really hard to make sure that we're able to translate these things not just at yearly conferences or in quarterly reports, but in almost real time. And I'm quite passionate about getting these kinds of tools worked on with clinicians to be able to kind of direct antibiotic use, but also to patients to be able to kind of make sure that the community is more well informed, because I think people are capable of taking this up. I mean, you saw that over COVID. People are completely capable of understanding if you give them the right tools to understand. And I think that would also help rebuild trust within, especially communities that have been traditionally experienced harm at the hands of medical research. So I think there's a couple of competing things going on at the same time. And yes, I do think that we need to continue to look for new therapeutics or new therapeutic approaches, even. But that is an ongoing battle. I think we should definitely work on the things that we know would be, um, able to contribute in a positive way first. So I hope that answers your question.
Yeah, no, it does. It's kind of an exciting time with the ability to transmit information the most quickly that we've ever had. We do have challenges with rapidity of transmission of information to understand how reliable that information is. But then also potentially thinking about what Emma was telling us about just that challenge between, um, hey, there are 14 mutations that we might see across two different genes. And if we just report the mutation, does the receiver of that information have the understanding of the context? And how do we transmit information in a way that we're not, sending essentially someone our terms and references for, like an iPhone, and we're just going to click accept. But so how do we transmit information not just quickly, but in a way that has meaning and accuracy, and that as soon as we know something, the half-life of truth has never been so short in the world, but including in science. Ethan, you've got your hand up.
Oh yeah, I also had a question for Samantha, if that's okay. I wanted to know if, in your opinion, you thought that with increased community prescribing, particularly from pharmacists, and a particular drive um, to move in that direction, whether that may, and your comments about particularly older people being sexually active, being exposed or infected with gonorrhea, who may not know it, and then present to these pharmacies, whether they may that may also be another factor in driving antimicrobial resistance with regards to this infection.
Yeah, absolutely. That's a really great point and allows me to segue into an even more particular point where I'm not David. David does not share this opinion necessarily, but I hate doxypep. It's a terrible idea. Um, and I can't say that strongly enough. Until someone tells me to not say that, I will continue saying that. I think that when you put there's a difference between enabling something that is setting a community up to fail in the long term and doing something where someone has autonomy in a situation. And I think that that distinction is not being made clear. We do have incredibly health literate communities, and we also have communities that aren't so health literate. And you should see the amount of people who are shocked when I talk about STIs in nursing homes. It's surprisingly common. It's something that people don't like to think about. But as you mentioned, I do think it is a problem. And also, there are other avenues, which anecdotally, through my work, I've been in contact with lots of different walks of life and people on different journeys. And specifically, there are many, many cases wherein people have gotten throat infections, and that's been better detected in recent years than it ever was previously. But there are many, many cases where people were on antibiotics for 8 weeks plus before learning that it was in fact a gonococcal infection. So I think that literacy needs to be both ways in this situation. Firstly, we need to put power in the hands of people and really do better at translating the science in terms of patients and making them a bit more aware and removing stigma wherever we can. But then also, sometimes I've been in rooms trying to explain to stuffier academics about how trans men may be at risk in the climate of doxypep if they're engaging in sex with men, and how a particular network, because of their biology compared to and their specific physiology compared to someone in the same community who has access to a protective factor that they don't have access to, there are completely different risk metrics there. So I think that behavioral literacy in practitioners and in researchers and in public health spheres is also really important and sometimes skimmed over.
Right. Look, you've both launched into exciting, controversial topics there. The anxiety of the medical profession when non-medicos are licensed to prescribe drugs, and we know, to be fair, that many antimicrobial stewardship crimes are being committed by medical prescribers, and I don't think it's entirely fair to suggest that all antimicrobial resistance is just going to be able to be attributed to pharmacy prescribing. But I think we all have work to do there, and I think that we're on a very exciting journey with doxypep. I have a strong recollection of one of my mentors here at this hospital when I was a registrar telling me that that HIV PrEP was going to be the sky was going to fall, and that we were just going to wind up with a whole lot of resistant HIV. And I think being aware of risks is really important, but also being aware of the greater context. And I have an open mind myself as to whether people who are at very high risk of significant bacterial STIs are going to wind up getting more antibiotic or less antibiotic overall if they're taking doxypep. I think the jury is out. In my work in infectious disease, I do worry about off-target drug resistance development in, for example, Staphylococcus aureus. But to be fair, the tetracycline boat has already sailed long ago for gono. So I think it's going to be a super interesting area. Gono is is just the standard bearer for development of resistance. And given any opportunities, Gono will always seek, find a pathway to more resistance. So I think this will be a very exciting area going forward, and we're not going to lack opportunities to think and argue and debate about the pros and cons of different treatment strategies and diagnostic strategies and prevention strategies. So, look, I want to on that I'd like to close the meeting. Thanks so much to our three excellent speakers who've really given us just gold this afternoon. I would like to thank all of you who took time out of your day to come and participate in this seminar, both in person and online, and the people who took the trouble and had the bravery to ask good questions. I failed to thank our sponsors at the start of this, so I'll do it now. I'd really like to thank Pfizer and CHU NEEM, who enable this session and this series. We do have a survey, but if you don't have patience and you're excited, you could click the QR code. There's immense personal satisfaction and improving the series for doing the survey. There's not other prizes at this stage, and you be aware that CRE Respond have many more upcoming education events in 2026. You will certainly be receiving some of those in your email. And there's lots of ways of engaging with CRE Respond, both in social media and as well as looking through the information that gets sent out. So thank you so much to everyone. Really grateful for your time, for your input. Look forward to seeing you again. Thank you.